A very good evening, esteemed professors, dear colleagues. On behalf of the Academic Club of DMIHER, I extend a warm welcome to each one of you today. We gather not only to exchange knowledge, but also to celebrate the spirit of academic excellence, innovation, and intellectual growth. Your presence here enriches this occasion. The Academic Club of DMIHER stands as a forum for intellectual engagement and scholarly pursuit. It cultivates curiosity, encourages critical thinking, and provides a platform where knowledge is shared, refined, and transformed into excellence. We are truly fortunate to have with us Dr. Aditya Nimkar Sir, Assistant Professor, Department of Obstetrics and Gynecology, SETH GMMC and KEM Mumbai.
Hi everyone. I hope I'm audible enough and I'm also clear. Is there any issue on my end? Kindly let me know so that I can begin my part.
So your audio is clear.
Okay, fine. So everyone, radiology and obstetrics. It's no secret that I who have done my residency in OBGY. I'm from the 23 pass out batch. Fortunately or unfortunately, the mind has been with OBGYN, but the heart has always been with radiology. It was the branch that I wished to pursue. And unfortunately, or fortunately again, I ended up marrying OBGYN. But still, as a matter of fact, radiology still persists as a deep burning desire of something that I would want to do more of. And today I'll be discussing every single trimester, every single thing that deals with obstetrics and radiology. Now, in my opinion, all the branches that are there in your hospital are interconnected, are very nicely interconnected with all other departments, with all the departments with OBGY. So, be it your medicine department, general surgery department, radiology department, patho department, every single team has a great offers a great deal of assistance to our department in OBGY. And radiology, in my opinion, is the biggest aid that we have, is the biggest assistant that we have to our daily functioning. And hence can never discard their presence. They are going to be always there for us. And today I am here to offer an obstetric perspective to this session. So, welcome to today's session of Echoes of Life. It's an amazing initiative. It is something that I'm grateful to be a part of, and I would like to thank the team from DMIMS for offering me this opportunity. So, before I go on for the images, let me first tell you what is going to be the blueprint or a roadmap for today's session that I'll be taking. So, when I talk about USG in obstetrics, of course, I'm not going to be talking today about the folliculometry part because that will technically fall into, or the infertility part will fall into the gynae session, which I'll be taking later. But in obstetrics, I have, of course, three trimesters. Of course, that's nothing that needs to be taught again. And each trimester, your ultrasound is going to offer you an extreme amount of insight into how the pregnancy is progressing, not just for the fetus, but even for the mother. There are going to be several aspects that I'll be looking at, wherein it will tell me a lot about how is the pregnancy even doing for the mother. And it is going to help me with a lot of predictions and a lot of things. So when I talk about this, in the first trimester, the various uses that I'll be using or I'll be using ultrasound in pregnancy is going to be first of all to check for the location of pregnancy. The most important thing that you have to first do is to confirm whether it's an intrauterine pregnancy and the patient is safe to proceed. Because of course, if it's an ectopic pregnancy, I cannot be proceeding with that pregnancy. The first very important thing that I would want to know is going to be what is the location when I do any ultrasound in the first trimester. Once the location is confirmed and it is confirmed to be intrauterine, I'll be looking at the viability. By viability, I would want to see if there is cardiac activity, if there is any fetal cardiac activity that I can visualize. Once it is visualized, I would say that now it is a viable pregnancy. And then, depending on whether it is singleton or multiple gestation, that very common phrase in the first trimester comes into play, SLIUG, that is single live intrauterine gestation. So these two aspects, when they are confirmed in a singleton pregnancy, it will be called as SLIUG, that is single live intrauterine gestation. If the viability is not yet confirmed or the cardiac activity is not yet seen, and I would want to do a repeat scan later on after a week or two to know whether it is there or not, in that case, I would just say single intrauterine gestation, that is SIUG. The live word is only going to be offered when I do the viability scan. After that is done, I've been recurrently saying about this S part, that is singleton. So the next thing that I'll be looking is if there are any multiple pregnancies, and if there are multiple pregnancies, then what is the chorionicity of it? Very important, chorionicity, because of course we know that whenever it is going to go towards monochorionic gestation, there are several very monochorionic specific complications that arise, like twin transfusion syndrome, TAPS, twin anemia polycythemia sequence, or TRAP sequence, twin reverse arterial perfusion, and all these things, SGA, selective growth, SGR, selective growth restriction, all these things are very classically associated with monochorionic twins, and hence I will have to amplify, or I'll have to step up the what do I say, the assessment or the evaluation of that pregnancy on a much more frequent basis. So chorionicity extremely important, because whenever it is dichorionic, it is just like two separate babies in their own houses who are staying together inside that uterus. So the main point over here is that the chorionicity is going to determine a lot about how the pregnancy is going to proceed in terms of the fetal well-being. Once that is done, once these things are done, then comes the most important part that is going to help me, that is dating. I'll be knowing what is the gestational age, and then I'll be able to know as to if the dates that she has told me, the last menstrual period, if it is accurate or not. And according to that dating, all my subsequent scans are going to be evaluated, so that whenever in the second or third trimester, late second or third trimester, there is going to be anything about fetal growth restriction that I am noticing, or small for gestation age, it is going to be on the basis of this first scan. Hence, it is of extreme importance that the earlier scan you do, the best date you will be getting. As the fetal size increases, your dating loses its accuracy, and the plus minus, जो हम लोग plus minus बोलते हैं, basically your accuracy of getting the exact expected delivery date is going to significantly reduce. Hence, it is very important for every patient to get a first trimester scan done. Remember, you cannot go to the subsequent thing before doing the previous thing. What does this mean? You cannot be directly going for dating without looking at the location. You cannot be going to the viability without looking for the location. Similarly, you cannot be doing dating without looking at the viability. You cannot have an intrauterine pregnancy but without cardiac activity and then give a date to it. No. Your dating will only be done on a scan that has the location, of course, intrauterine, and it is also a viable embryo. There is cardiac activity. You do not do the dating otherwise. So all these things are very important and have to be done in this order itself. This is about the first trimester. Once I'm done with the first trimester, the most dangerous phase of your pregnancy is done, wherein spontaneous abortions or threatened abortion, all these risks have been negated. Then I come to the second trimester. In the second trimester, the most important scan will be my NTNB scan. And along with that, I'll also be doing the uterine artery Doppler. I'll be coming to each one of these aspects. Now, NTNB scan is going to be my first scan that tells me about how the fetus is. Until now, I was only seeing how big the fetus is, or whether it is alive or not, and whether it is there in the right location. But now I'm going to be looking at the finer aspects, and those finer aspects are going to tell me whether that fetus is having any aneuploidy, or going to give me a hint about whether it is having any aneuploidy, or is it having any major gross body defect. And hence, that NTNB scan is going to be my first checkpoint towards having a healthy fetus. Along with that, the uterine artery Doppler is going to be a great predictor of future preeclampsia and fetal growth restriction. How? I'll be talking all about it in my. Is there any issue? Yeah. And I'm going to be talking about it, of course, when I will be showing you the images. Then I come to the later scan. I've been seeing at the finer, I'm seeing at the finer outcomes of my scans now. Now I'll be coming to something called as a level 2 scan, or what we also call as a targeted imaging for fetal anomalies, or simply put, the anomaly or malformation scan, whatever you call it, several names to it. Malfo scan, that is malformation scan, बहुत लोग इसको level 2 भी बोलते हैं. The most important scan according to me in pregnancy, because everything apart, you do not need just a fetus, you do not need just a live fetus, you also need it to be in a good condition. You need that baby whenever it is born aage jaake to have a good quality of life, and a good quality of life is only going to be offered when your level 2 scan is normal. You cannot just be having a baby but something that has a huge meningomyelocele. You cannot be having it that way. You need a proper anomaly scan so that the baby will have a good outcome in its future life. And hence, the most important scan is also going to be done in the late second trimester, that is between 18 to 22 weeks of gestation. Then, when I come to the third trimester, I have done with all these things. In the third trimester, I'm going to be looking at, most importantly, the growth scans, interval growth. Basically, now I have to just see whether the baby is growing properly or whether the placenta is not able to support the pregnancy that well. And if the pregnancy is not being supported that well by the placenta, then what is the reason and how early can I deliver is going to be told to me by Doppler. So these are all the things that I'll be looking for in an obstetric scan, and this is going to be my basic thing to be taught. Now, USG or USG in obstetrics, which falls under fetal medicine, is a vast topic. It's literally a parallel branch that you have after your OBGY residency. It's a proper fellowship that you have. And hence, for me to be discussing this in 1.5 or 2 hours is me not doing justice to my love that is fetal medicine. And hence, I'll be just overall covering all the images so that you, be it an undergraduate or a postgraduate at your level, you'll be able to get an idea of how to do the basics. Okay. So now coming to the first trimester scans, wherein I'll be talking about the location and viability. So when I talk about the location and viability, the first thing that I'll be seeing once it is confirmed that it's an intrauterine pregnancy, of course, that is the biggest prerequisite when you've seen the double decidual sign. The double decidual sign, as you can see over here, I'll be just drawing a green arrow. The double decidual sign. These are the two G sacs. So the not the two G sacs, basically the two decidual signs that we can see over here. So this is one of the confirmatory signs of it being an intrauterine pregnancy. So whenever I'm talking about an intrauterine pregnancy, this is how a gestational sac is going to look like. This is how a gestational sac looks like. Now just look at how regular and smooth the borders of this thing are. Just look at how smooth these borders are. There is no abrupt abnormal boundaries that this wall has. Now, just keep this in mind because once I proceed, I'll be able to tell you what is the difference and what is the significance of me telling you this. So now this is the first thing that I do whenever I have to date any pregnancy or whenever I have to determine how big this pregnancy might be. Ideally, dating should not be done at this point, but the importance of this is to determine whether this pregnancy will have a good future. Why do I say so? So when you look at this G-stack, you can see that I've measured three planes. One is this plane, the third one, and this is one, and this is two over here. So I've measured it in three planes. So the first thing that I've done is I've placed a probe. Let's assume this is a curvilinear probe. Let me assume that curvilinear is the abdominal probe, trans-abdominal probe. I've placed it in this way. This happens to be a transverse section that I've taken for the uterus. Once this is done, then I'll put it in a longitudinal plane. So whenever I do this, I have taken it in two planes that are 90 degrees to each other, and between them, I have taken three segments or three cross sections. So I've gotten a three-dimensional value. So you see that I have taken three dimensions, three values, and on the basis of this, I will be taking out the mean sac diameter. What is mean sac diameter? Mean sac diameter is basically the mean or the average of these three diameters, and that is going to be used for the calculation. The calculation is going to be done by the machine. You do not have to do it. The software has been fed into your computers, into your machines, USG machines. So it has to be a thing wherein you take these three diameters and not just rely on one single diameter, and the average of it is going to be helpful so that you know what is the gestational age. But the fallacy or the problem with this is that you're not seeing the fetus in this. If there would have been a fetus inside like this, let us assume there would have been a fetus inside, it would have been good enough to call it a viable pregnancy. But the bare minimum that you can do with this is you can approximately tell how old this pregnancy is, but I will not give an EDD, that is your expected delivery date with this scan wherein there is no fetus that is present. The first concept that you have learned over here hence is how to know and what is the significance of mean sac diameter. Whereas once the fetus has appeared inside, then you will be doing the proper dating and you will be giving an expected delivery date with the help of this fetus. Now over here you can see two structures. One is this, you can see, and the other one is this thing. It's a very amorphous structure, I would say. And by amorphous, I would want to say that I cannot really clearly make out where the head is, where the tail end is. All I can see is it's a straight line, it's in longitudinal line, and that is all that I'm able to see at this point of time. I'm not able to know where is the hand, where is the feet, where are the hands, where are the feet, where is the head, where is the rump. Rump is basically the buttocks of a fetus. The rump is what it is called in the early first trimester. I'm not able to make that out. All I can make out is ये सीधा इस direction में है and there is a circular structure around. This circular structure is my yolk sac, and this is actually my fetus. But this fetus, all I can see is, if I'm going to just erase these drawings, if I can see over here, there is going to be a hypoechoic region. You see, there is a hypoechoic region over here. This hypoechoic region is probably going to be, and most likely going to be, my cardiac region, where I'll be seeing fluctuations. Now, this is a still image, so I cannot obviously show you fluctuations, but if it would have been a video, you would have seen that there is small flickering of the heart. When this flickering is occurring, that is going to be suggestive or literally telling me that this pregnancy is viable at this point of time. आगे जाके it may abort, but at this point it is viable. And the point that it is flickering is enough an indication to tell me that I can take the crown rump length. Crown rump length. Crown is basically something that I wear on the tip of my head, and rump is my buttocks. So I'll be taking the entire length. You can see how they have measured from this point. You can see till this point, and they have mentioned it to be the CRL. So the crown rump length is going to be the distance between these two crosses, the length of that fetus, and that is going to be calculated by my machine. You do not need to know the calculations. They are complex calculations. The machine is going to give you a gestational age. And if you can see over here, for a crown rump length of 5.5 milliliters, it has given me a gestational age of 6 weeks, 2 days. And that is how it is going to be confirmed that this pregnancy is viable. Along with that, you can also see there is something more that is given. I'll come to that later. They have given more than 97%. So this indicates that this is more than 97th centile. What does centile or percentile mean? Centile means how many fetuses at this gestation, or for the given LMP that you have put an LMP, you must have put some LMP, that is last menstrual period. So you're going to have a gestational age through your LMP, and you're going to have a USG wala gestational age. So in this case, it is likely that for this LMP, this baby is more than, or this fetus is more than 97% of the babies at this gestation. So it might be the case that your patient has given you a wrong LMP. It may have been a few days earlier, later that she has mentioned to the LMP, but it is okay. Basically, this fetus is more than 97 centile. That is what it is going to tell me. Not that significant. The significant part over here is this is the dating scan. The most important thing that you can do is by taking the CRL. Now, as the fetus grows in size, now this was a 6 week fetus, whereas here it is a 12-week fetus. If I'm being more accurate, it is 12 weeks, 0 days. So now this is literally the double of this, and now you can see that there is a proper head that is visible. Am I audible enough? I hope I'm audible. Yeah, there is some disturbance. There is someone who has turned on their mic. Just turn it off, please. Yeah. So now this is a proper fetus. There is someone who has turned off something. Please turn it off. Yeah. Now over here, you can see that this entire fetus is seen over here. Over here, of course, I can now make out that this is the head and this is the rump. Rump is, of course, I've told you the buttocks part. Of course, these are the 2 feet that I can see, but see that I have not measured it from the head to toe. I have measured it from the head to rump again. So this is now going to be my new CRL. The CRL, which was earlier 5.51 mm, is now 58.85 mm. It is literally 10 times of it. So the length of that fetus has increased 10 times. It is now literally 5.8 centimeters. So even if it was an aborted fetus, I would have been able to see it with my naked eye, and that is how I'll be taking my CRL. This is a NTNB scan that is being done for this fetus between 11 to 14 weeks of gestation. I'll be talking about NTNB scan later on in the next segment, in fact. But this is a proper crown rump length that I can see. And of course, over here, you can see that there is going to be a fluctuating heart. So cardiac activity is going to be seen, and that is going to suggest that it is a good, well progressing pregnancy. Now, this was all about a good pregnancy, a healthy pregnancy. What are the signs that this pregnancy is not doing well or that pregnancy might just abort at some point? There are a few diagnostic signs and there are a few suspicious signs. Diagnostic signs are going to be diagnostic that this pregnancy has completely failed. You need to do suction and evacuation and you need to evacuate the uterus. Whereas suspicious signs are going to be the ones that will tell me that this pregnancy is very likely to abort, but it has not yet aborted, or this is not yet a missed abortion. It might, though it is very likely though that at some point in future this might abort. but I do not need to do a suction evacuation at present. I can just wait and call her back for a repeat scan. So what are those diagnostic and suspicious signs that is given by ISUOG? ISUOG is an international association of all the obstetricians who do ultrasound, and they have several guidelines. One of the guidelines, as you can see over here, is the diagnosis of miscarriage or missed abortion. Now remember that over here it is diagnosis. So basically these are the diagnostic points. Whereas something later that I'm going to show you is going to be suggestive signs. I'll come to this later, but before that, first of all, these are the diagnostic signs. So one of the first things is if it's a one-off scan. One-off scan basically is you do a scan and you're 100% sure that this is a missed abortion or a miscarriage is confirmed. Whereas a repeat scan may be required wherein you would give the benefit of doubt to a patient, but now that she has come back to you on a second or third, yeah, sorry. So the scan has been repeated, and now on a repeat scan is what I'm telling that patient that your pregnancy has not progressed that well, and now this is confirmed to be a missed abortion. So these are the two ways in which I can diagnose. So what are the criteria for that? On a one-off scan wherein a patient comes to me and I just give her a final report that this pregnancy is done with, you will have to go ahead with a procedure of suction and evacuation. In that scenario, it is going to be, just give me a second. Just give me a second. Yeah. So whenever this pregnancy is there and the pregnancy is fulfilling a few criteria like, first of all, the mean sac diameter is more than 25 millimeters, that is more than 2.5 centimeter, but without any yolk sac or fetal pole. Fetal pole is basically, I cannot see any fetus, that longitudinal small amorphous mass that I was saying. Nothing is seen. It's just an empty gestational sac, and the diameter has crossed 25 millimeters. Now, in this, if you see, this first thing that I showed you, there were two diameters that were crossing 25, but there was one diameter that was not crossing 25, which is why the mean sac diameter wouldn't be crossing 25 mm. Although there is no fetus or there is no embryo inside, but the mean sac diameter is still less than 25, which is why I cannot call this a missed abortion, because one diameter is still less. So it will have to be that the mean of all three is more than 25 without any obvious yolk sac or fetal pole. So the image did not have, the one that I just showed you did not have anything inside. There was no yolk sac, there was no fetal pole, but unfortunately, or fortunately, I would say for the patient, the diameter was not crossing this criteria. So either this criteria should be fulfilled or the embryo is visible, the crown rump length is measurable, it is more than or equal to 7 mm, but there is no evidence of fetal heart activity. So by the time a fetus reaches 7 mm, the fetus or the embryo should definitely have some cardiac activity. But if it is still not there, despite it being it having a CRL of 7 or more, in that scenario, I would say that this is a failed pregnancy, what we also call as an early pregnancy failure or missed abortion. What is the difference between missed abortion, threatened abortion, and inevitable abortion? Missed abortion is wherein the cervical os is closed, the cervix is closed, but the failed pregnancy is still there inside. The complete opposite of it is the os is closed, but there is no pregnancy, the body has already aborted it. That is what we call as complete abortion. Something in between is an incomplete abortion. Why? The fetus is still there inside, but the os is closed and the patient is bleeding. Basically, there are few bits and pieces of the gestational sac that are remaining inside, and the patient is bleeding because of that. That is called as an incomplete abortion. Whereas a threatened abortion is when the pregnancy is there inside. The cervix is also closed, but the patient is bleeding. So the pregnancy is threatening you that I will abort itself if you don't do something about it right now. So that is what is threatened abortion. And inevitable abortion is when the cervix has opened, the pregnancy is inside, but the cervix is open, you can do nothing to close the cervix, and the pregnancy will eventually just abort itself. So these are the various terminologies that we use. This diagnostic criteria is for missed abortion, wherein the cervix is closed and the fetus is completely, the embryo is there completely inside, and the patient is not bleeding yet. The other criteria is when the mean sac diameter is more than 18 millimeters, but without any embryo inside, and it's been more than 70 days. 70 days is 10 weeks. So by her LMP, her gestational age by dates is more than 10 weeks, but by ultrasound, the mean sac diameter is more than 18, but without an embryo yet. One more thing is when the embryo is more than 3 millimeters but without any cardiac activity more than 70 days after LMP. That is, your date's ka gestation age has crossed 10 weeks, but the embryo is still not having any cardiac activity despite having a size of more than 3 mm. These are the findings. These four are the criteria which you can just stick in your room wherever you're doing a USG, and you can just look at them. And if they are present, any one of these criteria, not all of them, any one of them criteria are fulfilled, then you will give her a diagnosis of early pregnancy failure or missed abortion. If any of these there is a doubt, do not give the diagnosis. Just tell her to come back after 7 days or after 14 days. And on that scan, if after you call her back after 7 days, if there is no embryo, but that embryo was there earlier, after 7 days, if there is no embryo now, then you give her a diagnosis of missed abortion. Or if the gestational sac is now more than 12 mm with or without the gestational sac. So basically, after a week as well, the gestational age has not increased, the mean sac diameter has not increased, or the MST has not more than doubled 14 days after the scan. So if it was 5 mm now, after 2 weeks, it should have been more than 10 mm, but that has not happened. This is going to tell me that this is a failed pregnancy. These are the criteria that you have to remember for confirmatory diagnosis of miscarriage. Now I'll show you a few images. You can see over here that the mean sac diameter over here, if you're going to calculate, it is going to be more than 25 mm. It is somewhere between 26.2 mm आता है अगर मैं इसका average निकालूंगा तो. You can see that this gestational sac is big enough. It is more than mean sac diameter is more than 25, but there is no fetus inside. There is no embryo that I can see inside. This is a confirmatory sign of missed abortion or miscarriage. Similarly, if you can see that the crown rump length is over here, you can see 9.3 mm, but there are no fetal activity. The fetal cardiac activity is not seen, which is why at 9 mm, no cardiac activity. I have to give her a diagnosis of missed abortion, again, confirmatory. Now, coming to what are the signs that are suggestive of miscarriage, I will not give her the diagnosis. I will tell her that you may come back after 7 days or 14 days, and then I will confirm, because, of course, you have to give the benefit of doubt to the pregnant patient. You cannot just tell her, go and abort this pregnancy, go and do a suction and evacuation. There's a 1 or 2% chance, even if there is a 1 or 2% chance that this patient's pregnancy might just become viable after a few days, you have to give her that, because pregnancy can be difficult for a lot of patients to conceive. They say that there's something informally said as this pregnancy is precious, this pregnancy is not precious. Why precious? Because the patient is having had multiple recurrent pregnancy losses, or this patient has gone undergone IVF. No, every single pregnancy, including a primary gravida at, let's say, 20, 22 years of age at your clinic, that is a precious pregnancy. Every single pregnancy is precious. So do not term a few patients to have precious, whereas the other ones as not being precious to you. Every single pregnancy is precious. So always give the benefit of doubt to your patient. So what are the signs that are suggestive of miscarriage? Suggestive of miscarriage is when the crown rump length is less than 7 mm, but there is no heartbeat. The mean sac diameter is between 16 to 24 mm, but there is no embryo inside, or the absence of embryo after 6 weeks of last menstrual period. So basically, her gestational age by date is more than 6 weeks, but there is absolutely no embryo seen. There is only a sac that is seen. Or if the yolk sac has grown so much that the diameter of the yolk sac, this yolk sac diameter that you are seeing, this is more than 7 mm, that is one of the signs that is suggestive. Or there is empty amnion sign. I'll show you what is that. Or there is a less than 5 mm difference between mean sac diameter and crown rump length. So over here you can see that this is an empty gestational sac. The mean sac diameter is only 19 mm, but there is no embryo inside. Also, you now see that how irregular are the margins. You had seen earlier how they were regular, but over here you can see how irregular they are. This is called as a crumpled G-sac. Crumpling is a definitive, not definitive, it's a sign that is suggestive of possibility of missed abortion. This crumpling or irregular G-sac is one more sign that is suggestive, but at this point, I will only tell her to come back after a week and I will then reassess her. But this is looking very likely that this is eventually going to be a missed abortion. So suggestive of missed abortion or miscarriage, but not diagnostic. Apart from that, this is what we call as a crown rump length of 6 mm. So less than 7 mm, but there is no heart pulsation. But at this point, I will not give her the diagnosis. I will tell her that I will want to wait for it to become 7 mm. I will call you back after 1 week. Apart from that, you can see empty amnion sign. Basically, your amnion is easily visible by 7 weeks of gestation. But if your amnion, this is your amnion, is visible, and this is of course your chorion, by the way. So this is your chorion, this is your amnion. Your amnion is seen, but you are not seeing any fetus inside. In that scenario, is anyone calling me? No. Okay. So if an amnion is seen, but you are not seeing any embryo inside, then even that is going to be a sign that is suggestive. See, the word important here is suggestive, not diagnostic of a fetal loss. So amnion is going to be easily visible by 7 weeks of gestation. And lastly, the part that I just told you, that the embryo difference or the difference between the crown rump length and mean sac diameter is less than 5 mm. So you see that this was the mean sac diameter and this green may was the crown rump length. The difference between them, if it is less than 5 mm, then you have to understand that the gestational sac is not increasing in size. For some reason, the crown rump length is growing, probably not growing, but the gestational sac is not increasing in size. That is again a sign of a or suggestive of, or it is going towards a missed abortion. This is about miscarriages. Does anyone have any doubt? Quickly tell me in the chat if there is any doubt. I would want to clear it right away. If anyone has any doubt at this point. Any doubt? Is everyone understanding everything that I'm saying? Any doubts yet? Has everyone understood everything? Please quickly tell me so that I can move ahead to the next point.
Yes,
Yeah,
sir.
this is irritating me as well, the typing. I don't know how to stop it. Anyway, I'll just move on. How do I stop it? This live caption thing, I don't know how to stop it. Screen has to be restarted from my end. Is my screen not visible? I think it is visible. My screen is visible, right? My OneNote is visible, no? Team, is the
So
OneNote
your screen
visible?
is visible. Yes, sir. It just says that it will end only after the meeting will go away. Like the real time text, it the at least it says that once the meeting gets over, only then will it stop.
Okay, fine. So otherwise it is visible, right? Now I'm sliding down. It is visible. I'm sliding my
Yes, sir,
screen
it
down.
is.
It is yeah, okay, fine, fine. Okay. Now I'm coming to my next important scan that happens to be the NTNB scan. So when I'm talking about the NTNB scan, now whenever I'm talking about an NTNB scan, this NTNB scan has a few prerequisites. You cannot be just doing it at whatever gestation that you want. It's a very there's some voice disturbance. Please mute it down. So whenever I'm talking about any NTNB scan, this NTNB scan has to be ideally done between 11 to 14 weeks. But this is not the primary criteria. The primary criteria is NTNB scan will have to be done between 45 to 84 mm of CRL. So whenever your CRL is between 45 and 84 mm, that is the only time when you can do a NTNB scan. Remember, if you do it before that, you're going to end up underestimating the lens. If you're going to do it after that, you're going to end up overestimating them. And when you're going to do a combined first trimester screening, what is combined first trimester screening? I combine NTNB scan with dual marker, and the report that I get is called as a combined first trimester scan. A combination of NTNB scan, when it also includes your tricuspid regurgitation, ductus venosus, along with your dual marker, is going to give you an accuracy rate of as high as 95%. So remember that your sensitivity increases to 95% of diagnosing an aneuploidy when you are doing NT, that is nuchal translucency, NB, that is nasal bone, ductus venosus reversal, tricuspid regurgitation, and your dual marker. These five things, when they are done, they will give you a sensitivity of 95%, as high as 95% for diagnosing any aneuploidy in your NT-NB scan or during that 11 to 14 weeks of gestation. So the most important and the strict criteria that has to be maintained is that it has to be between a CRL of 45 to 84, which roughly comes between 11 to 14 weeks of gestation. Now, what are the important things that I have to see in this? The important things that I'll be seeing in this is going to be, first of all, the nasal bone. This nasal bone, if you can see, I have measured over here. This nasal bone is measured over here. So if I'm going to draw a green line, this happens to be my nasal bone. but you can see that there is something shining over it as well. Now, this is not your nasal bone. Why? Because that is your nasal skin fold which is shining. So ideally, you have to see an equal to sign. Your equal to sign is going to be seen wherein the upper line is going to be your nasal skin fold, whereas the line below that is going to be your nasal bone. If you take nasal bone, sorry, if you take this nasal skin fold, you may end up overestimating and unusually normalizing the presence of nasal bone. In fact, if your nasal bone is absent in few patients with trisomy 21, and you end up assuming that this nasal fold is the one that is your nasal bone, you would end up wrongly giving the diagnosis of a present nasal bone when in fact it was absent for that female. Now there is a dilemma whether you should be looking at something called as a hypoplastic nasal bone. No. In Indian scenario, nasal bone is usually of a shorter length, usually. Secondly, the mere presence or absence of nasal bone should be looked at in an NTNB scan. You should not be commenting whether it is hypoplastic or not. The hypoplasticity should be mentioned only in your level 2 or your TIFA scan, wherein that is the point wherein you give the diagnosis of absent, hypoplastic, or present bone. In your first trimester or second trimester scan like NTNB scan, you can only give the diagnosis of absent or presence. You do not mention hypoplastic. Unnecessarily, if you give it as a hypoplastic thing, they will end up doing a CVS testing, that is choriovilonic sampling, which is not required. Remember that even if it is present, but you think it is hypoplastic in the NTNB scan, it will possibly grow till your second trimester ka TIFA scan is done. If it is still hypoplastic at that point is when you give a diagnosis of hypoplastic nasal bone, and then you can do an amniocentesis and know whether there is actual trisomy 21 or not. So the bottom line here is in first trimester it is only absence or presence. In the first trimester, sorry, your NTNB scan it is absence or presence, whereas in your TIFA scan it is going to be absence, presence, or hypoplastic nasal bone. Remember this very clearly. So the equal to sign is very important over here, and the lower part of it is going to be the nasal bone. So over here, I have measured the nasal bone. It is 2.5 mm. Of course, the hypoplasticity need not be mentioned, but it is 44.1 centile, which is normal. Less than 5 centile is said to be hypoplastic. Apart from that, I have also measured the nuchal fold thickness. You can see the nuchal fold thickness is this length over here. You see, this is my nuchal fold over here. This is my nuchal fold or the nuchal translucency. A lot of people say nuchal translucency thickness. No, it is your nasal fold or nuchal fold thickness that you measure in the TIFA scan, whereas you measure the translucency in your NTNB scan. The thickness is of the skin fold. When the skin fold has developed well enough, that is done in your TIFA scan, that is your level 2 or your anomaly scan. Whereas in your NTNB scan, it is only the translucency that you measure. This translucency is very important. Why? Now, this translucency, you see that this is the body's dependent part. And this nuchal translucency region is an area of hypoechogenicity. Hypoechogenicity is suggestive of fluid or water in it. Just like this amniotic fluid that you can see over here, the amniotic fluid that you can see over here is hypoechoic. Similarly, this part over here is also going to contain water, which is why it is hypoechoic. What is the significance? If you have any aneuploidy, any aneuploidy, be it trisomy 21, be it trisomy 18 or 13, whenever there is any aneuploidy, you will have some or the other cardiac defect. Cardiac defect के वजह से your heart is either going to be stiff or it is going to be non-compliant. It is not going to have a great ventricular function. And whenever you don't have a great functioning heart, you are going to have signs of heart failure. Signs of heart failure is one of them is going to be back pressure changes, which is going to lead to cardiac failure के वजह से anasarca, that is edema in the dependent parts of the body and in fact all the parts of the body. The dependent part over here in this fetus is going to be that nuchal region, jahan pe if there is accumulation of fluid or water, it is going to be suggestive of some cardiac defect that is attributable to your aneuploidy. The other implication of this is that whenever you have any aneuploidy, you are most definitely going to have some or the other lymphatic problem as well. And whenever there is any problem in any lymphatic, that is going to cause transudation of that lymph, especially in the neck region where your jugular plexus and all are coming, which is also why this accumulation of fluid can be suggestive of some gross abnormality in the fetus, that is your aneuploidy, which is why your nuchal fold thickness is very important to determine whether your heart has some defect or whether there is a bigger defect, that is some trisomy is existing in that patient. And hence, whenever your nuchal translucency is increased, it will indicate that the fetus is having anasarca, if you do not abort this pregnancy, or if you do not test this pregnancy, and if it is continued despite it having some aneuploidy, then आगे जाके इसको hydrops fetalis होने के chances बहुत ज्यादा है. So whenever you get a nuchal translucency that is more than 95th centile, then you will do a chorionic villus sampling and you will check it for all the karyotypes. Also, you will do a proper anatomical survey to see if there are any gross problems that are visible. This is about your NTNB scan. Does anyone have any doubt? There is also one thing that I've measured over here, that is the intracranial translucency. It is not important at your level. It is going to tell me about the fourth ventricle, the future fourth ventricle, not required at your point, at your level. But have you all understood everything until now? Quickly tell me, I will proceed. Any doubts? Please don't tell me about the screen. I'm very helpless about it. Just tell me if you all have understood the things until now.
Sir, do we have any like a normal value for this NT, normal value
Any no?
range
No,
instead of
normal value will
percentiles?
not be there. There's a reason to it. I will tell you the reasoning behind it. Let me just come back to my screen. Yeah. So now see, your baby is increasing in size. So when your baby is increasing in size, the value of NT or NB at 11 weeks is not going to be the same value for, or the same normal value for 14 weeks of gestation. And you cannot have such a broad normal range that you have that also encompasses your 11 weeks and also encompasses your 14 weeks, because with that you will end up missing the ones who have less or more of NT and NB. Now, if you ask me for that particular gestation age, let us assume that I'm doing a scan at 12 weeks, 1 days. For that weeks or for that gestation, I have a certain chart. I have an algorithm that is going to, or what we call as a nomogram. We will have a nomogram that will give me a certain percentile. So no, there is no normal value, but we have percentiles, which when you are now in this computer, we do not have that algorithm that was uploaded, but you can do it on your internet or on your computer if you have a software. I do have that software. In that software, it will give you the percentile. If that percentile is above 99 centile, then it is going to indicate that your nuchal translucency is increased. So there is no particular size or number that you have, but your percentile is what matters. Now, usually it has been seen that whenever your NT is more than 3 mm, then in that scenario, it is usually more than 99th centile. And all those patients who have, if you do not have the software, but if you have a normal USG machine which is giving you a value of more than 3 mm, then those are likely to have a centile of more than 99, and you will do a CVS for them. I hope this is clear by now, the question that you had asked.
Yeah, okay, sir. Okay, sir. Also,
Oh,
but please show some
But
clippings where we can identify like intrauterine bleeding of first trimester and cervical length
intrauterine
also,
bleeding.
sir.
Okay, I'll send it on the group if that's fine, because I do not have an image right now, but I do have it in my PC. I'll send it on the group if that's fine.
Yes, sir. Okay, and cervical length measurements.
Okay, fine. You want it for intrauterine bleeding?
Like, how do you find like threatened abortions to
A
calculate the
threatened
size of
abortion
the
is a clinical diagnosis. Remember that threatened abortion is a clinical
no, sir.
diagnosis.
Like to calculate the amount of bleeding which is inside, whether
Okay.
she is doing
So yeah,
ongoing
for that,
bleeding,
what we do is, yeah.
hematoma.
So that's a great question. So the thing is, the just the way I will send you an image, just the way you measured your mean sac diameter in your USG machine, you have a modality wherein you can measure the volume of any mass. So whenever I'll be seeing any patient with a subchorionic hematoma is what we measure, because that is the hematoma that is situated below the forming placenta in a three-dimensional plane, just the way I showed you how to measure your MSD. Similarly, we'll measure that clot. And once you measure that clot, you will get a value of how much of cc or how much of ml. Cc is just another way of calling milliliters of clot or bleeding is present inside the uterus. I'll send you a picture that shows you how a subchorionic hematoma looks like. The measurement is going
Yeah,
to be the
okay, sir.
same way I measured your MSD. Okay?
Thank you, sir.
Okay. Now that I've spoken about the NTNB scan, now I'll be coming to the most important scan that I had mentioned. That is going to be my anomaly scan. Let me just put it on the group that I'll be beginning. So now anomaly scan will encompass or entail me looking at every single structure of the body. A few are important things, a few are not that important things, because if I have to go and see everything in detail, I can see literally the skin folds of my ear, if there is presence of helix and anti-helix. It can go up to me looking whether the patient's finger, one finger is present or not. Hrithik Roshan ka ek extra finger hai. But is it something that is important to be seen in an anomaly scan? Is that important? I can have a patient who, let's say, has cystic fibrosis but doesn't have a gallbladder. I cannot end up missing the gallbladder. So it is very essential. So there are a few essential things that have to be seen, and there are a few things that are good to be seen. It's a good thing if I give them a diagnosis of a patient having one extra finger, but no other anomalies, polydactyly in a single hand. But it is not acceptable if I'm going to miss an absent gallbladder, or if I'm going to miss out on something like a tetralogy of Fallot. So what are those crucial things and what are those not so crucial things is what I need to determine. Because agar mujhe karna hai, I can keep doing the scan for, let's say, 2 or 3 hours and be looking at every single structure, but that is not feasible for me. Even financially, it is not going to be feasible for me to be doing a scan for 2 to 3 hours. So the ISUOG has given a set protocol wherein they discuss the most important unmissable things that you have to look on a level 2 or anomaly or a malformation scan. They are called as the 20 plus 2, not 22. 20 plus 2 planes of anomaly scan. What are those 20 plus 2 planes? Now, this is what is called as a 20 plus 2 planes. The reason it is called as 20 plus 2 is there are 20 planes that I have to see, and there are 2 sweeps that I have to make. This is why it is called as 20 plus 2, and hence I told you do not call it 22. So this is the first sweep, this is the second sweep, and in between you have your 20 planes that you have to check for. What is the meaning of sweep? Let us assume this is my mouse and this is my USG probe that I'm placing on the abdomen. Let us assume that this bottle is my fetus. A plane is going to be when I place this ultrasound probe on this plane and I keep it static and I study everything that is there inside the cross section of this bottle. This is one plane over here. This is going to be the, oh my God, it is leaking. The other plane is going to be over here. The other plane is going to be over here. There are these 20 planes that give me an idea about the static structures. But what is a sweep? A sweep is I keep my hand, but I do not keep it static. I just run it through the fetus, once in this plane and the other one in this plane. So this way, when I'm going through a longitudinal section, because see, this is going to be a longitudinal section in which I drive, is going to be my sweep 1, and this is going to be my sweep 2. Sweep 2 is transverse section. Sweep 1 is going to be a longitudinal section. These are the 2 sweeps. Whereas when I place it statically on a single plane or a single point on the fetus, those are going to give me those planes wherein I'll be studying the static structures, be it my heart, be it my gallbladder, be it my abdomen, all of these. This is the difference between a sweep, which is the dynamic movement, and a static plane. So the first sweep is a longitudinal sweep, and in that longitudinal sweep, I'll be seeing one important thing that is going to be my vertical if it is in cephalic presentation or breech presentation. And the most important thing that I'll see is the cardiac activity, which is intrauterine demise hua hai ya nahi, is what is going to be told to me. Whereas sweep 2 mein, I'll be running it through the entire fetus from the head to toe. Hence, I'll be seeing all the organs quickly after I'm done with the scan, which is why sweep 2 is like a revision of the entire scan that I've done, just to make sure that I've not missed out on anything. Whereas sweep 1 is to give me a basic idea of what is the lie of the patient, if the of the fetus, if that fetus is alive or not, and where is the back, where is the front of that fetus. So sweep 1 and sweep 2, and iske beech mein there are 20 planes. So in the 20 planes, in the first 3 planes, yeah. Yeah. In the first 3 planes, I am going to see the spine of the fetus. I'll be showing the images of each one of these. In the next 3 planes, I'll be seeing the head of the fetus. So the head and spine are done in the first 2. Between the 7th and 10th, I'll be seeing everything in the thorax, be it my lungs, be it my heart, be it my ribs, everything in it. In the 11th to 13th plane, I'll be seeing the abdomen, which will include me seeing the kidneys, the adrenals, the gallbladder, and everything inside the diaphragm, the bowel loops, of course, for echogenic bowel, and the aorta. Every single thing in the abdomen is going to be seen on the abdominal planes. In the 14th, I'm going to see the pelvis of the fetus. 15 to 17 are going to be my limbs. I'll be seeing if there is any bone that is missing, if they are short, if there is rhizomalia, or a focomelia, anything of that sort. And lastly, the 18 to 20 is the face. I'll be seeing the face, wherein I'll be seeing whether the eyes are properly placed, whether the nose is properly made, if there is binder's facies, that is there is a flattened nasal bridge hai ki nahi. I'll be seeing all of that in my, and cleft lip, cleft palate hai ki nahi, that is going to be seen in the face. And sweep to me, I'll be just running it from a top to bottom so that I scan the fetus to see if I've missed out on any of these. How does it look like on an USG, or how does it look like on USG? So in the first plane that you can see, it is a little rough, but I hope you all can understand this. In the first plane that is I am seeing over here, the first plane is the first plane that I'm going to be seeing is going to be everything that is see about the spine. You can see that the entire fetal spine is seen. Apart from that, I'm also seeing the overlying skin on it. The overlying skin on it is also seen, and the spine is seen completely. So the spine and the skin covering it is important. So when I see the 1 to 3 wala plane, उसमें मुझे क्या क्या दिखेगा? First of all, I'll be able to see if there is situs inversus. I'll be able to see whether the stomach and heart are on the same plane or they are in the opposite directions. I'll be able to see diaphragmatic hernia. I'll be able to see the skin का defects, that is meningomyelocele. You ask me how diaphragmatic hernia. तो यहाँ पे जो मुझे lungs दिखते हैं, this is my diaphragm, एंड यहाँ पे अगर लंग्स के इधर मुझे ऐसे बॉवेल लूप्स दिख गए, आई कैन अंडरस्टैंड दैट देयर इज डायफ्रामेटिक हर्निया. Apart from that, I can see a meningocele if it is present like this, something that is bulging outside the skin. Apart from that, spina bifida, similarly, basically spinal defects, sacral agenesis, and coccygeal teratoma. So all of these things that will disrupt the continuity of my back are going to be seen on the first plane. In the second plane, basically, these are the first three planes: plane 1, plane 2, and plane 3. In the next three planes, that is plane 4, plane 5, and plane 6, it is going to be my skull that I'm seeing. So in that, I'll be first seeing if there is holoprosencephaly, wherein the lobes, the hemispheres are not well made. If there is banana-shaped cerebellum, which is suggestive of either Vermeer hyperplasia, vermis is that part which joins the two cerebellum, or if there is something like Dandy Walker. Cystic hygroma is going to be seen if there are any posterior fossa cysts that are seen, that is fourth ventricle ke idhar, lemon-shaped skull, occipital encephalocele, basically from the occipital region, if there is any encephalocele that is coming out, if there is skin edema, that is anasarca, and ventriculomegaly. So over here you can see that there are multiple things that you are seeing. First of all, this is your skull bone in entirety. Please mute the mic. Secondly, over here I can see that there is a CSP, that is cavum septum pellucidum. Then I have my ventricles over here. Now remember that this ventricle is seen, but this ventricle over here is not going to be seen because the skull bone over here is going to cause acoustic impedance. Basically, it is not going to let the USG rays fall on it or the USG waves fall on it, which is why I'm not going to be able to see this. But this is seen because from the fontanelles, opposite side ka ja pa raha hai. So if I have to see this, yahan ka, if I have to see the ventricle on this side, I'll have to suitably place the probe so that it bypasses this. And from the fontanelles or between the gap in the skull bones, I can see this ventricle. So these are the ventricles that I can see. Apart from that, I can also see the choroid plexus that is inside. If there is anything that is like hydrocephalus, these ventricles are going to be enlarged. Apart from that, I can see the thalami over here. The thalami. This is the beach ka tentorium, or the fax, you can call it. This forms the arrow sign. This arrow is going to always point towards posterior. So this is going to be a posterior, that is your occipital region, and this is going to be your anterior region. This arrow of the thalamus is going to be very important in that sense. So I can see the thalami, and finally I'll be able to see the cerebellum. You see, this is the cerebellum, and uske beech mein I can also see the vermis. This is the vermis. So this is the transcerebellar plane, this is the transthalamic plane, and this is the transventricular plane, wherein I'm seeing the entire structures in my head. You can see over here how they have made, these are how the planes are going to look like. Next, the next planes are going to be for the thorax, 7, 8, 9, 10. 4 planes for the thorax, wherein I can see all the cardiac defects like AVSD, that is atrioventricular septal defect, CPAM, that is cystic pulmonary adenoid malformation, double aortic heart, everything about the heart. And in this, I'll be talking about the 2D echo at the latter end of this session. So this is going to be the 4-chamber heart, wherein I can see the 4 chambers of the heart. I can also see the axis of the heart. See, the axis is pointing towards here, the apex is pointing towards here. Over here, I can also see the aorta and the spine over here. So this is my anterior, this is my posterior, because I can see the vertebra and the ribs beginning over here, and also the aorta is posterior. And this is pointing towards the left side. I can see the ventricles over here. This is going to be my left ventricle, this is going to be my right ventricle, right atrium, and left atrium. This is called as a four-chamber view. After that, I'm going to see something called as a left ventricular outflow tract. This is the left ventricular outflow, which will be the left ventricle over here and the aorta over here. Apart from that, I'll also see the right ventricular outflow tract, which is going to give me my right ventricular, this is going to be my pulmonary trunk, the two branches, and this is going to be my right ventricle. These are the planes wherein I'll be seeing. Apart from that, the three vessel trachea tract, wherein these are my three vessels over here, and over here small one more vessel. So this is going to be my pulmonary artery, this is going to be my aorta, and this is going to be my superior vena cava, and along with that over here I'll be also seeing my trachea. And finally, these are my four planes that will give me a lot about the heart. Apart from this, I can also see that the lungs that are present over here are normal. There are no obvious bowel loops that are seen. So congenital diaphragmatic hernia can also be seen on this plane. So then these four planes are for the thorax. The next are for the abdomen, wherein in the abdomen, I'll be taking the abdominal circumference. You can see that a dotted line is drawn over here. The abdominal circumference is seen. Then I'll be seeing the cord insertion. If the cord insertion is problematic, or if there is anything in there, I can see omphalocele, I can see gastroschisis over there, or if it is displaced thoda outwards, then there can be ectopic bladder, basically the bladder being outside. And I'll be also seeing the spine on both the ends, and at the spine, I'll be seeing the two kidneys. These are my kidneys over here. So the abdomen is going to give me all these things. On the abdominal plane, I can see the stomach over here. I can see the adrenal glands over here, the aorta again over here, and this is my umbilical vein that is going towards the right side. So these are all the things that I'll be seeing. On an abnormal basis, if there is anything to be seen, then first of all, ascites, if there is hydrops fetalis will be seen. Renal agenesis agar hai to dikhega. Duodenal atresia dikhega. There will be dilated bowel loops. Echogenic bowel, very important, soft marker for Down syndrome, gastroschisis, omphalocele, if there is any renal pelvic dilatation, and an absent stomach. Absent stomach is going to indicate your problem in your upper gastrointestinal tract, something like esophageal atresia. Lastly, you have the pelvis. In the pelvis, you will be seeing, there are not too many things that you'll be seeing in the pelvis. It is not even in fact mentioned over here, which is why in the limbs, you will be seeing your femur length. You will also be seeing your tibia and fibula will be seen, and in your hand you'll be seeing the humerus, ulna, and radius. The most important part of seeing this is एक तो femur length is going to be useful for doing your fetal weight कितना है वो determine करने के लिए. Apart from that, you will also be able to see if there is any absence of bone, all the radius associated anomalies, and very importantly, skeletal dysplasia. If your bones are shorter than what they should be at that gestational age, your percentiles are going to give you that. If they are less than that, if they are less than 3 centile, third centile, then it is indicative of skeletal dysplasia. Skeletal dysplasia is something that, if thanatophoric, that is lethal, will need to be aborted. So all the important things about the bones, that is limbs, will be seen on that. So flexion deformities and skeletal dysplasias are going to be seen. One more thing is talipes, that is CTEV. Club foot is also going to be seen in this plane. How will you see CTEV if you ask me? The answer to that is, when you can see this tibia and fibula ka plane, you can see the foot like this. But if instead of the foot, you're able to see all the toes looking at you like this, then it is going to be indicative that the foot is outturned and there is CTEV. The last is your plane of your face. In that plane of your face, you're going to see the upper lip, nostrils, and nasal lip. You can see over here, the nose is seen very beautifully. You can see the nose. Over here, it is your upper lip. Over here is your lower lip. ये पूरा upper lip है, in fact, and over here is your lower lip. This is indicative, you're continuous here, so there is no cleft lip, there is no cleft palate. This is going to be seen. Apart from that, you'll be seeing the orbits. Orbits are both your eyes. In the orbits, you can also see, if I'll be marking this point over here, you can see the lens over here. The lens that you can see, this hypoechoic part is your lens. If there is any absence of lens, or if it is completely white out, it will indicate congenital cataract. Congenital cataract is going to be indicative of torch infection. So you have to see these orbits. If these two orbits are too close to each other, that is going to indicate hypotaylorism. If they are too far, it is going to indicate hypertaylorism, another marker of Down syndrome. And lastly, this is your facial profile. in that facial profile, you are going to see multiple things. First of all is your corpus callosum to look for callosal dysgenesis. Secondly, it is your nasal bone to look whether it is absent or it is hypoplastic. Next, you're going to see the palate in these two forms. If your palate is having any discontinuity over here, then you'll be able to know that there is cleft palate. Apart from that, you can also see that this is the upper lip and this is your chin. The chin is not too far behind. If it would have been too far behind, it would have either been micrognathia or retrognathia. Again, something that is indicative of some genetic defect. And lastly, your angle. This angle that you can see of the nose is the frontomaxillary angle or the frontonasal angle. If this is like this, it is too much increase the FMF angle more than 141 degree agar hai, it is going to be indicative of binder's facies. Binder's facies is one of the signs that you see in a patient with chondrodysplasia punctata, something that occurs with warfarin toxicity. This is what you'll be seeing on the 20 planes. And finally, the two sweeps, wherein the first sweep is going to help you know the longitudinal axis of the body. And lastly, the transverse sweep is going to be from the head to toe so that you can see if you have missed out on anything. And this is going to be your basic 20 plus 2 planes. If you see properly, we have not looked at several important things that you think are important, like your number of toes. You have not looked at the ears, toes or fingers. You have not looked at the ears. So all these minor things are not noticed. If you have time, do it. They are good to do, but these 20 things are must do. You cannot be missing out on them. Did you all understand the 20 plus 2 planes? And these are the anomalies that you can see when you're doing it very properly. Any doubts? Take a screenshot of this if you want. Any doubt until this point? Any doubts whatsoever? Quickly tell me so that if there are no doubts, I can proceed with the subsequent one.
Sir, I didn't understand one thing. Sir, I wanted to ask one thing. When you were discussing about NTNB scan, you mentioned about something like don't label it like this, otherwise they will unnecessarily get CVS done as of now. When you're doing NTNB scan, can you just repeat that point? I didn't understand that at all.
Okay. So the thing is, in a lot of fetuses, if your nasal bone, only the nasal bone, this is only for the nasal bone, is present, but it is hypoplastic in your NTNB scan, in that scenario, your nasal bone may become of normal size by the time you do your level 2 scan. Now, if it becomes normal at your level 2 scan, you have unnecessarily done a CVS procedure on that patient after the NTNB scan, which is why only note it if it is absent or present. Do not mention it to be hypoplastic in your NTNB scan. To give the diagnosis of hypoplastic, wait till your level 2 scan is done. Do not give the diagnosis because it will unnecessarily lead to an intervention, and the CVS has a slightly more chance of causing a miscarriage, and it is also a lot more painful, and you will unnecessarily do it in that patient, which is why a hypoplastic nasal bone is not a correct thing to do in your in an Indian setup in your NTNB scan, whereas it is what is to be seen only in your level 2 scan. Did you understand it now?
Yes, sir. Thank you, sir.
Okay. Okay. Did everyone understand? Quickly tell me in the chat. If it is understood, I'll be quickly proceeding. Please do not tell me to explain these planes again. Someone has said explain it again. Please don't do this to me. The planes explain part will be too elongated. And please don't ask for the recording. That recording, the decision is not yet taken. And we may not even give this recording. So please do not ask for the recordings right now. Which weeks are considered to be accurate? ISUOG guidelines say that the best dating scan is between 11 to 14 weeks, but the overall consensus is the earlier you do a scan with fetal cardiac activity, the better it is. So the best scan is going to be between 6 to 10 weeks whenever you're doing cardiac activity presence wala scan at that point of time. But ISUOG says that even at 11 to 14 weeks, it's a good thing to do. But the earlier you do, the general consensus is it is better to be used for dating scan. Okay. So coming to the next part of the session, that is going to be my third trimester. I'll come back to 2D echo at the end of this session because it is not that important. Okay, yeah. Now that I'm done with my NTNB scan, your anomaly scan, that is malformation scan, and everything looks to be normal, that is when I'll tell the female that you can be rest assured and we can proceed with the pregnancy. What are the red flag signs that I can get? Red flag signs, the most important ones that I've given you over here are already there. If any of these are there, if there are gross things that you see, then you may have to give a decision for MTP. But these are gross, very bad diagnostic features. There are things like which are between, which are not normal, but which are not even suggestive of something that is grossly abnormal. That is what we call as a soft markers. Soft markers. What is soft marker? Soft marker is basically something that is indicating or suggesting the presence of some abnormality or some aneuploidy, but is not definitely telling you about it. So each and every system has one soft marker, and all these soft markers are mostly going to be suggestive of the Down syndrome. But with the presence of any soft marker, you do not give a decision for MTP. You do a karyotyping or an amniocentesis followed by karyotyping or CMA, and then you give the diagnosis. Whereas if any of these gross abnormalities are present, like bilateral renal agenesis, you do not need to do any invasive test. You can directly give a decision for MTP. So what are the soft markers? So in your renal system, it is your renal pelvic dilatation. If your renal pelvis is more than 4 mm and or until 28 weeks of gestation, or more than 7 mm after 28 weeks. In your central nervous system, you have dilatation of ventricles, that is ventriculomegaly, more than 1 centimeter. In your musculoskeletal system, you have short long bones, especially a short femur. In your gastrointestinal system, you have echogenic bowel. Echogenic bowel is basically your bowel loops are going to be echogenic. They are going to be easily visible. Echogenic matlab bowel ka color jo hai, echogenicity is equivalent to the bones that are surrounding it. Bones kaun sa? You have your ischium, ileum that you see in your pelvis. So your bone ka and your bowel ka echogenicity is the same. It is indicative of some meconium that is inside. That meconium is going to be because of hypoperistalsis, reduced peristalsis of your bowel. Reduced peristalsis because in trisomy 21, that is Down syndrome, your digestive enzymes are not proper, which is also why they have malabsorption syndrome and celiac disease. And that is why your microvilli also don't function properly. That is why there is going to be stasis of meconium, and that meconium, because of stasis, a lot of water is going to be absorbed and they will become stones inside your bowel. That is going to give it the appearance of echogenic bowel. That is why your Down syndrome will have echogenic bowel. Apart from that, in your cardiac system, you can have endocardial cushion defects and all. More soft markers will include absence of nasal bone, of course, a very important soft marker. And in your heart, you will have aberrant right subclavian artery, URSA that we call it. So all these are the soft markers that you'll be looking at. And if they are present, if more than one are present, there is a chart that you follow. There is an Excel sheet jo milta hai, जिसपे you have to keep on adding them and you get a relative risk. If that relative risk is very high, that is more than 10, then you have to definitely go and do amniocentesis, and you have to follow it by, remember this, chromosomal microarray. The diagnostic test of choice now for amniocentesis or for looking at any aneuploidy is, if the patient is affordable, then it is CMA now. It is no longer karyotyping, because CMA is going to give you a lot more insight into your karyotyping. Earlier, it used to be karyotyping along with fish. Fish, so definitely not, because fish can miss out on a lot of things. The only advantage of doing fish, that is fluorescent in situ hybridization, is that you get the report in 2 to 3 days, whereas your karyotyping gives you a report in 14 days. The only good thing about fish is it gives you an earlier report. But now you have to do a CMA if your patient is affordable enough. Avoid doing a karyotype. Karyotype करने का भी सिर्फ एक ही फायदा होगा कि पैसा थोड़ा कम लगता है, 3-4 हजार कम लगता है. That is it about all your soft markers. Now coming to the third trimester. When I come to the third trimester, my important aspects are going to be monitoring the growth. So growth scans are going to be very important. So when I do a growth scan, I have to look at a few planes and I have to take those few measurements so that the hadlock is a formula, is the person who gave that formula. The computer is going to do that for you. It is going to calculate and give you the fetal weight and the gestational age as well. So those few things are head circumference and biparietal diameter, abdominal circumference, and femur length. Now over here you see that this is a third trimester. You can see the third trimester ka fetus hai. Third bhi nahi, late second trimester ka fetus hai. At this point of time, you can do this, by the way, at any time during the second and third trimester. The growth can be done anytime after second trimester. The first thing that I've seen over here is, this is my biparietal diameter that has been measured. The biparietal diameter has to be measured from outside to inside. So outside of the skull on one end to the inside of skull on one end, or from inside here to outside over here. You do not encompass the outside diameter if the inside has been taken at this point. It cannot be from inside to inside or outside to outside. It has to be from outside one skull bone to the inside of the opposite skull bone. Apart from that, I have also taken the head circumference. The head circumference is taken completely outside. This fulfills my 2 in my head ka criteria, or in my head. the ideal plane to take it is going to be the transthalamic plane or the transventricular plane. Whenever you take this head circumference, two things have to be seen. Posteriorly, you have to see preferably your thalamus or your lateral ventricle that is present over here. I prefer to see the lateral ventricle because it's a better gestation increases, the ossification of your bones of the skull increases. So seeing the ventricle becomes a little difficult. This has to be the posterior point that you see. Anteriorly, it has to be your CSP, that is cavum septum pellucidum. Only when you see these two things anterior posteriorly, that is going to be your ideal plane. Why? Because head circumference can be taken at this point, it can be taken at this point, this. Also, it can be taken in a this plane, or this plane. How do you know the ideal plane? The ideal plane is only going to be given if posteriorly तुम लोग को ventricle या thalamus दिखे and anteriorly CSP दिखे. Only that is going to give you the correct plane for looking at your head circumference and biparietal diameter. Once you do the biparietal diameter and head circumference, it will give you a gestational age. Corrected gestational age is going to be given. Over here, you can see by biparietal, it is 22 weeks, 4 days, and by head circumference, it is 22 weeks and 6 days. After that, I'll be seeing the abdominal circumference. Abdominal circumference, may I see it is taken completely outside. And what are the important things that I see in it? This first is the umbilical vein in a hockey stick sign. This is the hockey stick sign that we call. Next, I have to see the stomach. I have to also see the adrenal gland. Now, this is something that is a little difficult to see. So you may or may not see, but at least the umbilical vein and stomach have to be seen. The aorta has to be seen and the inferior vena cava has to be seen. Practically, even if you're visualizing the umbilical vein and your stomach, it is going to give you an accurate plane. One very important point to be noted here is that you cannot have multiple ribs that are seen, because if multiple ribs are seen, then it will indicate that you have taken a oblique section. So if multiple ribs are seen, it will look like this, dono side pe. That is not accurate. You only need to have one pair of ribs that are seen on both the ends. That is going to tell you that you have taken it in the proper, correct horizontal or transverse plane along with the umbilical vein and the stomach. These three things, if they are seen, if you can see the adrenal gland, that is excellent. But even if you see these three things, it is a good enough way to look at your abdominal circumference. Lastly, the femur length will have to be measured. The femur length will have to be measured from one end of diaphysis to the other end of the diaphysis. काफी बार यहाँ पे you will see the epiphysis that is not yet fused. Do not include them. You have to measure it between both the diaphysis and it will again give you a gestational age. Of course, this is not of the same fetus, it is of a different fetus, all these images. Once you take all these images, it will finally give you the effective fetal weight that you can see has been given over here. The effective fetal weight will only be available once you're done taking these 4 measurements. And this is how you do a routine biometry. To call it FGR, that is the growth not being proper, a scan that is done 4 weeks apart has to show a substantial stoppage in the, you have to also make, you get a software that gives you a dating, ऐसा वो तुम लोग को points बना के chart करा के देता है, so that you see कि ये बराबर से जा रहा है कि नहीं. If it falls by 50 centile से गिरता है, मतलब पहले it was let's say 78 centile, but after 4 weeks it has fallen to 26 centile. So basically the fall is of 52, that is more than 50. अभी इधर आ गया. That is going to be indicative of a significant fall between two scans, and that is going to be suggestive of FGR. I'll tell you the definitions later. But this is about biometry in the second and third trimester. This is something that all obstetricians should definitely know and not be relying always on a radiologist, because it is going to save your time as well as their time from doing just biometries. Has everyone understood this part well enough? If yes, I will proceed on to the last part, that is dopplers. Has everyone understood? Is there any doubt?
कुछ भी मत कर यार ऐसे भाई बोल दिया.
Okay. Mohak, please mute your chat. Yeah, thank you. Okay. Now coming to the last part. Once it is confirmed that there is some fetal growth restriction or there is some problem, I have to do a few scans. Those are called as Dopplers. Now over here, those Dopplers, what are the Dopplers that I can do first of all? The Dopplers that I can do are going to be, the earliest that I can do is an uterine artery Doppler. The next is going to be the umbilical artery Doppler. Then I have MCA Doppler. And then I have the ductus venosus Doppler. These are the four important Dopplers that I have to know and that I have to do for patients. This is optional. This is only done if the umbilical is not showing great signs or if there are signs of some anomaly or in the NTNB scan. Otherwise, these three are to be done regularly for all. When I talk about doing Dopplers, there are a few characteristics. Those basic characteristics will be spoken to by Dr. Jitendra about how to characterize a certain wave. I'll be talking about how and why does FGR occur. Now, the first thing that I'll be talking about is this is a uterine artery Doppler. Do not look at the direction. The direction is not important. The direction, if it is in this direction as well, it is okay. In this direction, it is also okay. It should just not be the case that there are two waves in each one of them. यहाँ पे भी है positive में भी है negative में है, वैसे नहीं होना चाहिए. It should be in one particular direction. Now, over here, you can see that there is something called as PS that is written over here. That is peak systolic velocity. ये बहुत बड़ा peak systolic velocity. This peak systolic velocity that is given over here is more than 60 centimeters per second. For any uterine artery Doppler, the peak systolic velocity has to be more than 60 centimeters per second. This is 133, so of course it is acceptable. यहाँ पे आता है वो 60 वाला mark, around this much. तो अगर इसके नीचे होता है ये waveform, this would have not been an acceptable Doppler. I would have had to do it again at other point. वहां पे मुझे एक और point ढूंढना पड़ता है जहां पे ये peak systolic velocity properly आ रहा है. So this is the characteristic of uterine artery. How is it significant and from when should you measure it? The ideal and the first measuring point has to be between 11 to 14 weeks. That is when you do the NTNB scan. Why is it very important? The value has to be less than 2.4. Which value? This value. You can see the left uterine artery PI. This value. Now this is done at 11 to 12 weeks of gestation and this value is almost near 2.4. What is the significance of this uterine artery PI? So now, whenever there is any chance of preeclampsia, you already know, I'm not going to be talking about it much in detail because it's a radio session. You already know that your trophoblasts are going to invade your uterine vessels, the spiral arterioles of your uterine arteries. If this is your normal uterine artery, if this is your tunica adventitia, ये ऊपर वाला, यहाँ पे तुम लोग का आ गया tunica media, that is your muscular layer, and the innermost is going to be your tunica media. This is your tunica media, that is your innermost layer, and this beach में is going to be your, sorry, tunica intima हो गया innermost, or middle is going to be tunica media. Now यहाँ पे you can see that the total available space for the blood flow is only this much. But this is okay for a non-pregnant gynae uterus. For a pregnant uterus which is having the baby, I cannot have only this much of blood supply, I need more. So what do the trophoblasts do is they destroy the tunica intima and the tunica media. So what happens is this was my vessel, the inner two layers are destroyed and only the tunica adventitia is kept intact. And now there is a larger area. Of course, it is very easily visible. The resistance has gone down for the blood flow and an increased amount of blood flow is going to take place to the fetus and it will grow well. If this is to fail, that will lead to hypoxia of the fetus. Why? Because jitna blood chahiye tha utna nahi aa raha hai. This hypoxia is going to release anti-angiogenic factors. Anti-angiogenic factors like SFLT2 and soluble endoglyne. These two factors are going to be released in my blood circulation. These are going to destroy all the angiogenic factors like VEGF, that is vascular endothelial growth factor, and it is also going to destroy PLGF, that is a placental growth factor. These two were good factors that my body needed. These were the bad factors that my body didn't need. Once these two are destroyed, this will lead to fetal growth restriction because the blood flow is not adequate. Plus, this will lead to maternal vasoconstriction that is going to reflect as preeclampsia. Now, the earliest signs to this is going to be seen when the placenta is developing, that is till 12 weeks of gestation or at this point of time. That is when the second wave of trophoblastic invasion between 12 to 16 weeks is going to take place. If I am to find that the uterine artery PI, the mean uterine artery PI of both the uterine arteries is more than 2.4, then I can do something about it by starting aspirin. Aspirin is going to cause multiple things. It is going to destroy thromboxane A2, which was a vasoconstrictor, and it is going to increase the production of PGI2, which is a a vasodilator. So even if these trophoblasts are not doing their job properly, aspirin is going to try expanding these vessels. It is going to try dilating these vessels. It is also going to cause its antiplatelet action to prevent platelet aggregation in this area. That will help in prolonging the pregnancy and delaying the onset of FGR. Remember, it will not prevent FGR or preeclampsia. It will only delay its onset and reduce the ill effects of an early onset FGR or an early onset preeclampsia to the mother. That is why aspirin can only have a value if it is started before 16 weeks, and hence your uterine artery Doppler has to be done between 11 and 14 weeks. Definitely. A lot of people do it between 20 to 22 weeks. At that point of time, the value has to be less than 1.4. But the problem is, at this point, you can only predict that this female may have आगे जाके उसको हो सकता है preeclampsia, but you can do nothing about it now because aspirin cannot be started at this point because the trophoblastic invasion has taken place and nothing can be done now. So over here you can see it is borderline, it is reaching 2.4, almost 2.4 है, so it is borderline. मैं borderline patients को भी aspirin start करता हूँ, but अगर strictly protocol follow करूँ तो more than 2.4 आता है तो definitely करना है. So this is about uterine artery pulsatility index. Pulsatility index is a measure of the resistance of the vessels. Next, I have my umbilical artery Doppler. Umbilical artery Doppler mein the peak systolic velocity is not that important. What is important over here, you can see is this is a systolic wave and this is a diastolic wave. Over here, I can see that both are in the same direction and both are present. Whenever they go absent, like in this scenario, kidhar gaya re? I'm not gotten that image, unfortunately, but okay. Now, this is what you see in a patient in whom there is a normal flow, wherein systole में भी flow है, diastole में भी flow है. If there is FGR जो progress होता है, in that scenario, your waves are going to first look like this, which is absent end diastolic flow. Systolic flow है, diastolic flow बिल्कुल भी नहीं है. This is called as absent end diastolic flow. Absent end diastolic flow happens when there is 50% destruction of your placental vasculature. If this is not corrected, then it will lead to a reversal of flow like this. This is called as reversal of end diastolic flow, which is indicative of a destruction of almost or more than 70% of the placenta. Now, why should this happen? Now, the reasoning to that is this is your placenta, this is your umbilical cord, and this is your fetus over here. If you look at your umbilical cord, it is going to have two umbilical arteries and one umbilical vein. Two umbilical arteries and one umbilical vein. But I have drawn umbilical vein in red and I have drawn umbilical arteries in blue. Why is an artery in blue? Because the artery and vein, the nomenclature is not based on the oxygenation levels, it is based on the direction of flow. Because the blood in the umbilical arteries is from the heart to the placenta, that is away from the heart, is why it is called as an artery. Whereas this is called as an umbilical vein because the blood flow is from the placenta to the fetal heart, which is why it is called as an umbilical vein. It is bringing blood back to the heart. This is going to be, of course, more oxygenated and this is going to be completely deoxygenated blood. So the fetus has two vessels to remove the deoxygenated blood and one vessel to bring the oxygenated blood to its heart. Now, whenever there is, please mute. Yeah. Now, this is how the umbilical arteries are coming and they are forming what we call as the tertiary villi. ये जो tertiary villi है, यहाँ पे there is going to be oxygenation that takes place and after oxygenation, the blood is going to go back to the fetus. This oxygenation takes place in the tertiary villi over here. यहाँ पे जो है मैटरनल स्पाइरल आर्टेरियल्स आते हैं और ये स्पेस में वो स्पाइरल आर्टेरियल्स ब्लड स्पिल करते हैं फ्रेश मैटरनल ब्लड एंड यहाँ पे ऑक्सीजनेशन टेक्स प्लेस. Now this is how a normal circulation works. Now if there is something like Apla syndrome or the patient has a predisposition to preeclampsia, these spaces will have fibrin deposition. There's going to be fibrin that is going to be deposited at these villus structures. There's going to be fibrin. There is going to be a fibrinoid necrosis that is going to take place. Once this fibrin deposition takes place over here, these spots where the oxygenation was supposed to take place is deranged. And unfortunately, because of this, the blood is not able to flow properly. This will increase the resistance to the flow in the umbilical artery because the blood is not able to push the blood beyond these obstructions. This will lead to an increase in the resistance in the umbilical artery, what we also call as increase in umbilical PI. If this doesn't stop, or if the baby is not delivered, at some point the blood will just stop moving. When the diastole is done, that is going to be called as absence of end diastolic flow. Basically, when the systole is there, the fetal heart is pushing the blood. Diastole जब होता है तभी heart relax होता है. Once the diastole is done, there is absolutely no force on the blood. It should by itself go to the placenta, but because of these blockages, it is not able to go itself, and it has become static during the end diastolic phase. That is what is going to be called as end diastolic flow. If it is still not corrected, then now the blood is going to start flowing reverse. The blood is going to start flowing back to the fetal heart every time the diastole ends. That is going to be called as reversal of end diastolic flow. If even this is not corrected, if this is my fetal heart, and if the blood is coming back to my, this is my left ventricle, right atrium, and right and left atrium, the blood is going to start coming back through the aorta, because aorta ka hi branches hai umbilical arteries. It will keep coming back. It will come back to the left ventricle. From there, it will go to the left atrium, and through the fossa ovalis or foramen ovale, it will go to the right atrium, and right atrium se back into the IVC. ये जो IVC है, it is connected to the umbilical vein through a vessel called as the ductus venosus. So if the back pressure increases so much, then there will be eventual reversal in the ductus venosus as well. And whenever there is reversal in the ductus venosus, it is indicative that the heart has failed completely. And if the heart has failed completely, the baby may die at any point, which is why reversal in the ductus venosus is said to be a terminal event. And when the baby is not delivered within a few minutes or within a few amount of time, some amount of time after the scan is done, the baby may die. So this is a terminal event, whereas reversal of end diastolic flow is said to be an ominous sign. Ominous matlab bad, anything bad can immediately happen. But agar ductus venosus mein hai, the bad has probably already happened. Even if you deliver the baby alive, it may still die because the heart has already failed in that fetus. It is only waiting to die. That is about reversal of end diastolic flow and reversal in the ductus venosus, or to be more specific, A wave reversal in the ductus venosus. The ductus venosus waveform I can show you over here is this. This is a ductus venosus, very classical ductus venosus waveform. Over here you can see that यहाँ पे ऐसा लग रहा है reversal है, but नहीं, this is an artifact because यहाँ पे there is still some positive flow. If this positive flow would have not been there, in that scenario अगर ऐसा कुछ दिखता, ऐसा पूरा, that would have been called as reversal of end diastolic flow. यहाँ पे there is still some positive flow, but it may anytime become reversal. This is impending reversal. There is no such term. It is just an informal way of saying it. But अगर ये पूरा negative में चला जाए, there is nothing positive left. This is called as reversal in the ductus venosus. It's a bad thing to happen. And if this is diagnosed in the NTNB scan, it is indicative of a heart that is already failing in your NTNB scan. Matlab the heart is stiff. Matlab there is possibility of some aneuploidy that is there. Again, your risk in your combined first trimester screening for an aneuploidy is going to increase significantly. So ductus venosus is not just important in your NTNB scan, but also in your FGR. And what is the diagnostic criteria that you use? Your diagnostic criteria is going to be your Delphi consensus. Delphi consensus mein you can see over here, your ductus venosus is going to be one of the last things that will change. And this is the criteria that you'll be using. You can just take a screenshot. I'm not going to go deep into this because I've already discussed this in another session on another platform. So this is your diagnostic criteria for fetal growth restriction. For every absent end diastolic flow, you have to deliver it before 34 weeks or at 34 weeks. Reversal of end diastolic flow is to be delivered between 30 to 32 weeks. And ductus venosus reversal is to be delivered immediately, irrespective of the gestational age. One more scan that remains is your MCA Doppler, MCA PSV. Very simple. Whenever there is fetal anemia and whenever there is hemolysis, your blood velocity is going to increase because your RBCs are destroyed. Your RBCs are destroyed, so your viscosity of the blood is low. Less viscous blood is going to flow very rapidly. So your peak systolic velocity, or what we also call as the MCA PSV, is going to increase. If this MCA PSV is more than 1.5 multiples of median, this is a statistics ka method which your computer is going to calculate for you. If it is more than 1.5, then it is going to be suggestive of significant fetal anemia, for that you will have to do a chordocentesis and check the fetal hematocrit. If the hematocrit is less than 30, then it is going to be an indication for intrauterine transfusion. Very important when it comes to Rh negative isoimmunized pregnancies. Lastly, coming to 2D echo, not something that is that important at your level, but यहाँ पे, as you can see, this is a fetal heart and these are the planes. वो planes जो तुम लोग को दिख रहे हैं, at which you will get each view. So 4 chamber view at this level it is going to be taken. You can see 4 chamber view यहाँ पे लिया गया है. 4 chamber में you can see this 4 things that you can see over here. Similarly, your abdominal situs view में तुम लोग को situs inversus की heart या stomach यहाँ पे है और heart भी यहाँ पे है. So it is situs solitus, that is the same side. This is a normal thing. 3 vessel view में you are seeing your pulmonary artery, aorta and SVC along with your trachea. Left ventricular outflow tract में you can see your left ventricle and aorta and your right ventricle. Also you can see membranous intraventricular defect भी दिखता है, ventricular septal defect भी दिखता है between your right ventricle and left ventricle. Right ventricular outflow tract, that is your RVOT, is seen over here. Your two pulmonary trunks are seen over here. And all these are very important for seeing various cardiac anomalies, not important at your level. This is your usual 4 chamber view that you can see. This is your right ventricular tract. You can see the various nomenclatures, and finally your 3 vessels and 3 vessel and left ventricular. Unfortunately, I cannot go on too long. Dr. Jitendra is yet to speak. This is the last scan that I would want to show. This is a classic ring of fire appearance, ring of fire because of this ectopic pregnancy that is there. Richly vascular, ring of fire, very rarely seen. Classical sign है, बहुत कम बार दिखता है क्योंकि most of the patients come to us with ruptured ectopic. ये already rupture हो चुका होता है and hemoperitoneum उनमें दिखता है. And with that, I would want to conclude my session. It was a 2 hour long session. I would want to apologize if it was too long. I hope everyone understood this. I would want to hand over the dais to Dr. Jitendra if he's still available. I hope everyone understood. And thank you so much from my end. Please let us know your feedback on the group that we have made, WhatsApp group. I would love knowing your feedback. This has been one of the longer sessions that I've taken. So thank you so much, everyone. And thank you.
On behalf of the Academic Club of DMIHER, I take this opportunity to extend a heartfelt gratitude to Dr. Aditya Nimkar sir for his enlightening session on obstetrics and gynecology with specification in ultrasound. Your insights have not only deepened our understanding but also inspired us to appreciate the immense value of this diagnostic tool in medical practice. We are truly grateful for the time, effort, and knowledge you shared with us today. Thank you, sir, for guiding and motivating us on our academic journey.
Thank you so much. And thank you for this opportunity. It was a great session. I'm looking forward to the next session, the gynae session. I hope we can materialize it and make it happen. Thank you.